So what we see here, that kidney disease causes hypertension, and hypertension causes kidney disease. And sometimes it is a vicious cycle which we cannot decipher. What came first, the chicken or the egg? And together these constitute almost 40% of our patients with CKD. And therefore, if we catch these two diseases, diabetes and hypertension, and today we are talking hypertension early, we will prevent major problems and postpone what might be the ultimate event. If you can catch this early, give the patient extra 20, 30 years of life, of good quality life. Next slide. So the current armamentarium of drugs available for blood pressure treatment, these are the antihypertensives, and I must point out today that the most useful ones come from the right side, and then we come all the way around this circle. There's the ACE inhibitors, ARBs, diuretics, beta blockers, alpha blockers, direct renin inhibitors, then central sympatholytic drugs and vasodilators. So these together form the armamentarium available to us. Next slide. However, all universally, whether the patient has hypertension or CKD, the universal recommendation is nowadays to start with ACE inhibitors, ARBs, either of the two, both equally good. The cardiologists like ACE inhibitors, the nephrologists like ARBs, because ACE inhibitors make people cough. The second choice is either diuretic or calcium channel blockers. Now, today, this is the accepted method of starting treatment with every hypertensive society, cardiac society, and renal society. Next. So let us see how hypertension hurts the kidney. You see on the left a beautiful diagram showing you the way that the blood in the arterial system from the renal artery comes to the glomerulus via the afferent arteriole, circulates inside the circulation of the glomerulus, and then comes out from the efferent arteriole. And this is the place where filtration takes place, and it is concomitant and proportional to the pressure inside. It is a pressure-mediated filtration which brings the tube down, fluid down into the collecting system all around like this, and with it some protein gets leaked out, which gets quickly reabsorbed from the proximal convoluted tubule. However, if this intraglomerular pressure increases either by the force of the systemic pressure coming into this, then only will you get the filtration to take place. And the more the pressure, the more the filtration. Now you see here better picture, more magnified, of how these filtration takes place through these glomerular capillaries, which have on their inside they have the endothelium, then a basement membrane, and outside they have this what is called the foot process. These pearlish blue substances come from the the epithelium, which is also called the podocyte. The podocyte is a cell which has multiple feet. So can I remove this? I don't know. My picture is getting this. See, what should I do to remove this, please? Sorry for the slight interruption. Yeah. So you're seeing here that this grayish cell is a podocyte and has multiple feet, and between the feet are the slit diaphragm. Through this, the process of filtration takes place. It's better magnified here. And in the next slide, please. Yes, you see it even in a better dimension. So what happens here is that the damage to the podocytes in the glomerulus due to the high systemic blood pressure, or with normal blood pressure also intraglomerular pressure increases by various mechanisms of pressures within the afferent and efferent arteriole. And this pressure causes damage to the podocytes, and the protein starts leaking from those slit diaphragms, and the protein leaks into the tubules, causing protein So it comes out from in from the tubule. It comes in large quantity. In trying to reabsorb, not everything does get reabsorbed, and much comes out into this area called the interstitium. And in the interstitium, it is an unwanted substance. It is unnecessary. It causes inflammation by various cytokines, and the inflammation ultimately leads to fibrosis. Oh, what happened? Hello, what happened? Yeah, okay. So the protein in the interstitium causes inflammation with cells, with white cells, and fibrosis thereafter. And the fibrosis that takes place here around these collecting ducts and the vasa, there's a vasa recti of the circulation, which come from the efferent arteriole and then become the venules and come out into the urine. So I'm sorry, into the vena cava through the renal veins, not the urine. Sorry. So the protein leakage from damage to the podocytes is what hurts the kidney. Next slide. Next slide, please. And that squeezes, if you see carefully here, that squeezes these vessels because the fibrosis there. All these vessels that you are seeing get squeezed, and therefore the flow into this glomerulus is reduced. And that's why the GFR starts falling. So the damage starts here, the vessels get squeezed, and the kidney damage of fibrosis starts falling. Whereas now the protein starts coming into this urine and finally into the what one passes into the toilet. Next slide. And you see a very nice picture of this turtle-like chap. This is the podocyte with its nucleus and these little unusual animal that you are seeing. And there are millions of them, billions of them, not millions. And this is what gets damaged. Next slide. Yeah, here we go. It just shows you photo micrograph, electron micrograph of these podocytes and how they will look after they get damaged. These are normal. These are damaged material which you are looking at. Next slide. And you see a normal glomerulus. You see a glomerulus later, but here you see those who are familiar with kidney. But you also see this onion peel vessels. So the pressure damages not only the glomerular vessels, but the arterioles of the kidney. And this onion peel artery, if you remember your Boyd's pathology textbook, they will describe this onion peel arteries, which cause severe damage to the kidney. And this is how it finally looks all messed up, not this healthy looking thing. So this is early nephrosclerosis and this is late nephrosclerosis. Next slide. And this is how you assess the damage. The albuminuria is the urine albumin creatinine ratio, which is the amount of milligrams per creatinine excreted. So it obviates the use of 24-hour urine. When you do 24-hour urine, it leaks in the house, it leaks in the hospital premises, it's incorrectly collected, some urine is passed with the stool, you don't get. So the useful thing on a day-to-day basis, without having to collect the 24-hour urine, is the UACR. Just see what this is again. I can't make out why this keeps happening. I don't know. I don't know. Tell me what to click. Get rid of it. Okay. So here we go. Oh, it's gone again into another mode. It becomes a problem. I should have full screen. That's fine. Oh, but this keeps coming back. Okay. Yeah, that's fine. All right. So next slide, please. And the important thing is that if you detect it and give no treatment, you will have a very rapid turnaround and breakdown, and within 4 to 7 years, especially if there is a malignant hypertension supervening on on a simple early nephrosclerosis into malignant nephrosclerosis, between 4 and 7 years, this will go to dialysis. On the other hand, a delayed intervention may take you to 9 years, And if you do a good job, an early intervention will take you to 11 years or even more. So, this is the point to make, that it's beneficial to have early intervention to move and give the patient good life and good quality of life. Next slide.